International Conference of Indian Association of Palliative Care. So the conference is from tomorrow. And the last is I was in Hyderabad attending the the workshop on Children's Palliative Care Leadership Program. So much has been happening. I have been learning so much on palliative care. And today in this session, we will be learning and discussing about terminal care and pharmacy issues. Another very important aspect of palliative care, because as we integrate palliative care at the diagnosis of an advanced illness, the need for palliative care becomes more and more as the patient deteriorates and goes into the end of life phase. So let's learn what it involves to provide an effective end of life care. And this session will consist of two didactic lectures by Dr. Anil Tandon and Ms. Gauri Godbole, as Sangeet has mentioned. And then a case presentation will be done by Ms. Nilima Chetri. So to introduce the faculty, you all already know Dr. Anil Tandon from the week 2 session. And so Gauri Godbole is a specialist clinical pharmacist in aged and palliative care at Gosford Hospital, New South Wales, where she's leveraging her extensive experience in community pharmacy, hospital pharmacy, and academia to provide comprehensive care in her current role. He has achieved notable milestones such as being a qualified dementia practitioner, conducting impactful research, publishing extensively, and presenting regularly at national and international forums. Gauri's remarkable contributions to pharmacy practice were acknowledged through her receipt of a prestigious Society of Hospital Pharmacists of Australia, New South Wales State Achievement Award in 2022. That's amazing, Gauri. Congratulations and welcome to the session. And our case presenter today, Ms. Nilima Chetri, is a clinical nurse at the Central Regional Referral Hospital in Gallipoli, where she is currently working in the surgical ward. She has a master's degree in mental health. Welcome to you, Nilima, and thank you for agreeing to do this case presentation. And as usual, please keep posting your questions in the chat box and ask yourself after the presentations. And with that, I would now like to hand it over to Dr. Anil. Over to you, Anil. Thank you.
Thank you, Tara. Just checking that I am audible as well.
Yes, you are. You are audible, yeah.
Sangeet, do you mind, like you did previously for me, do you mind displaying my slides and then clicking them forward as we go?
Yes, sir. Sure.
So thank you, everyone. So terminal care. So if we were, as much as possible, to try to remain patient-focused, research has been done into what are the important things that patients themselves want when they are dying. And so the research has consistently shown a number of common themes. As one would expect, good pain and symptom management. They don't want to have their dying phase prolonged unnecessarily. They would like to have some sense of control of what is happening. And that's certainly important because being unwell, medically unwell, entails a lot of giving over control. Either control is given over to the illness or it's given over to the hospital staff or the doctors and the nurses. They don't want to be a burden on others, and they want to, as much as possible, have strong and strengthen their relationships with others. From the patient's family member's perspective, the suffering of their loved one is really of paramount importance. And in particular, what they perceive their loved one has gone through will often be remembered by them for many months or years to come. And it can actually worsen their experience as well. Thank you. So I haven't actually, I've just sorry, clicked something wrong there. So I haven't actually already sent out these handouts, but I will send these. I've got just a few handouts to distribute via Sangeet, and so we don't need to dwell on that. But this is perhaps what I had mentioned on that previous slide in a little more detail. Thank you. So when a person is entering the terminal phase, and by that, really we're talking about the last hours or days of a person's life. Ideally, there has been preparation that you, as the doctors, nurses, allied health staff, have done beforehand. And really, that's the conversations with the patient and their loved ones about a number of different concepts. One is goals of care. So what are we trying to do in our treatment for this person? Is our goal that we're trying to cure the illness? Is the goal trying to prolong a person's life? Or is it actually just providing supportive care? And that's our goal. What are the values and beliefs of that person? And so trying to get them to tell their story as to what's important for them and who they are as an individual will definitely help frame the treatment that we give. What are their expectations about the treatments that we're going to offer? And ideally also, where would they like to die? And so what might be appropriate in one person earlier in their life will not necessarily be appropriate later on. And so that might be something like cardiopulmonary resuscitation, or it may be less aggressive treatment, such as something as simple, potentially as simple as intravenous fluids, nasogastric tubes, or whether we give antibiotics. And so that's really brings into play the art of medicine, is to try to work out the difference when we would normally sustain life, but now we might be thinking that it is not beneficial, and we don't want to, for example, in a person who develops a chest infection, necessarily give antibiotics, because it may be that administration of the antibiotics is not consistent with what their goals are, what's important to them. It may tie them to hospital, those sorts of things. Thank you. So there are a number of pointers to when a person is going to enter the terminal phase. They become very weak, essentially bedbound. They will become more drowsy and they will have difficulty concentrating. They'll be less interested in what's going on around them. They may be confused. Before they become bedbound, there will be more falls, incontinence either of urine or bowels. They will lose their appetite. They won't be eating or drinking as much, and they will struggle to swallow medications. Thank you. So again, this is just a more detailed summary of those particular pointers. And so the critical issue here is that making the diagnosis of dying is actually not straightforward and requires us to actually step back from the patient's care and think about it and work out, is this person just receiving treatment for a chest infection or some other problem, or have they now entered the terminal phase? Thank you. So if we see a number of those pointers, we need to talk to both the patient and the family. So just to begin with, I just will talk about, well, what will be the things that we might say to the family? So explanation is paramount. It's very important, because the family may actually be themselves unsure as to what is going on and think that the patient is actually giving up, or that they have control over these changes. And as a result, they might start to get frustrated with the patient or angry. And they may say, why aren't you eating? Or why don't you get out of bed? And why don't you come and join us when we're talking? If we give the families that information, then they can adjust their schedule, particularly as it is so common nowadays for family members to live in different cities or even different countries from the patient. And if we have this knowledge ourselves, then we need to give the relatives a chance to prepare themselves. Otherwise, they may say, but I did not know that it was going to be so soon. And unfortunately, what will very often occur is that there will be an escalation in the deterioration. In other words, a patient will become more sick much more quickly. And if we don't give that warning to the family, they won't be present. They may not have the opportunity to say goodbye. When we are communicating, it is obviously understandable if you feel nervous saying these things. And so you can give a time frame and you can say, well, it is not this person is not going to live for many months, but maybe they might live only for a few weeks or a month. Or you may say, we think that they are going to live several weeks, but it might be as short as days. And so you can give a wide range to the time frame, rather than being specific and say they are only going to live for 10 more hours and then they will die. And I have seen that happen when a patient has been in the intensive care unit and the ventilator tube has been removed, and the doctors might say they're going to die today. And then the patient survives sometimes several days or a week. So that, if we are very specific, that can be also distressing to the family. Thank you. So we also need to provide recognition that they're struggling, and it's very difficult for the family members, and encourage them to say, you're doing a good job, or keep on coming in and being with your loved one. This might be the first death that they have experienced, and so teaching them what they should do, that it's important for them to continue to talk. Just the gentle holding hand is very important. And then explain what is going on, because not all of what the patient is demonstrating is actually always going to be distress. Sometimes these are normal noises or changes that we see. I will often, when I go and see a person in the terminal phase who might be, by that stage, they are unresponsive, I will say to the family, if I think that the patient is comfortable, I will say, I go and visit many people in this situation, and I can reassure you that your loved one is actually very peaceful. I do not think that he is in pain. And I can compare him to other people I have seen who are not as peaceful as your loved one is. Thank you. So again, another checklist for you to have, which I will send later. Thank you. So whilst the communication is being held with the family members, the nursing care is absolutely important. And I won't spend a long time, obviously I'm not a nurse, but this is absolutely critical. So the good care of the mouth, especially when patients are breathing at the end of life with their mouth open, the mouth will dry out very quickly. The lips will become cracked and painful. The tongue may start bleeding. The gums need to be cleaned, and as do the teeth. Pressure care, so turning the patient. When the patient is being turned, to prevent pressure injuries, we need to also monitor for if the process of turning the patient is painful, then you may actually want to do it less frequently. Stopping vital signs monitoring. There is no need to measure the pulse or the blood pressure or the oxygen levels. Making sure that the patient is kept clean with their bowels and their bladder. Not everyone will need to have a catheter in their bladder. What does the bed space look like? So if the patient is in hospital, have we removed the intravenous pumps, for example, the other pieces of equipment? Has the pajamas been changed? Are the bed sheets nicely made? All of these things will make a very big difference. Has the patient had the opportunity to have their hair shampooed and combed? If they're a man, have they had their beard shaved or their moustache trimmed if that is normal for them? Thank you. So it is also important to talk with the patient if appropriate. And so this will obviously be prior to the patient entering the terminal phase. And so talking to them about and this is obviously if they want to know, and it may be that they actually know before even we know. They will say, "Doctor, I think that I am dying," or "I know that it is soon." And sometimes patients have said that to me, and I've said, "No, it's all okay." But actually, we see as the days pass that they were correct so often, and they know more than what we might be able to tell from our knowledge or from a blood test. They may ask and want reassurance, when will this be over? Because they may feel that they don't want to continue living. And if you say that it is going to be soon, they will be at peace. They might also ask what it's going to be like. Will they have pain? What will my family go through? And talking about that will be very important. Thank you. So prior to looking at the specific symptoms, we would look at the medicines that the patient is receiving. So many patients are taking tablets that used to be important but aren't now. So that might be iron tablets, vitamins, potassium, blood pressure medicines, cholesterol tablets. They're all very easy to stop and would be most unlikely to cause any problems. It is a little more tricky to work out when should we stop a diuretic, how long to keep the patient on insulin, if they have antiarrhythmics or when they are on steroids. If appropriate for most of these medicines on that second line, I would generally suggest keeping them going until the patient is actually no longer able to swallow, and then they could be stopped. It might be an easy decision to make, but explaining that to the patient and the family can take some time. With all of these medicines that we are going to prescribe, we need to think about the route of administration. So I have done some work in India, and there are many hospitals where I have worked where even in the terminal phase, the medicines are given intravenously. Here in Australia, it is common practice for us to give medicines subcutaneously through the cannula just inserted underneath the skin, usually in the abdomen. We don't tend to commonly here in Australia use medicines by the rectum, but that can be done. So we'll just want to now look at a number of different symptoms. I will talk on pain and shortness of breath, and then Gauri will discuss respiratory tract secretions plus delirium. Thank you. Before going on to pain, I think that it is important to touch on the issue of food and fluids, because this is something that comes up in all cultures, and I would imagine that in Bhutan as well, that there may be a lot of concerns from family members about whether their loved one will be dying of starvation or dehydration. And it may even be common practice in your hospitals for doctors and nurses to give feeding or fluids at the end of life in the terminal phase. But it's actually, in the research that has been done, there is very little evidence to say that that is beneficial. And there is a significant body of literature to say that there may be harm associated with that. And one of the things that I certainly try to do with all of the treatments, and I think food and fluids can be viewed as a treatment in the terminal phase, is ask myself the question as to, is this treatment actually improving the person's comfort? Is it potentially making them more uncomfortable? Or am I undecided? Is it neutral? So a patient, the family who is concerned about dehydration, that's a very challenging conversation. And it may be that we do see that when we give fluids to a patient who is in the terminal phase, there is a risk of fluid overload. The metabolism changes, the ability of the cardiovascular system to handle fluids when the body is shutting down is reduced, and there is definitely a risk of fluid retention in the dependent parts of the body, in particular the sacrum and the legs, but also in the lungs. But it is not a clear-cut correlation. And so I try to not overstate my understanding or what the literature's understanding is that, and so if a family member's very, very keen for me to give fluids because they are concerned about dehydration, I will, but then I will closely monitor the lungs and the rest of the patient's examination on a daily basis so that if fluid retention does become a concern, I will warn the family members that if that develops, then I think that we really should stop the fluids before it causes distress. Always remember that the patient is dying because of the underlying condition. They're not dying because they're not eating or not drinking. And similarly, they're not eating and drinking because they are dying. And this is a normal part of the dying process. Thank you. So as mentioned, sometimes a time-limited trial will be important, especially if there is disagreement. I think an exception will be if a person has a dry mouth. I will always show the family, myself if need be, how to do the mouth care with the swab or the gauze, just to moisten the lips, to put some cream on the lips, because being well hydrated will not relieve the problem of a dry mouth, in particular if the patient is mouth breathing. And sometimes we forget that even these sorts of relatively simple treatments can actually serve to create a physical barrier between the patient and the loved ones. And then the staff themselves will also concentrate more on the fluids and less on the patient and how they're looking in the bed and what needs to be done for their comfort. Thank you. So pain is very common, even in non-cancer patients at the end of life. So people dying from heart failure, from end-stage lung disease, end-stage kidney disease, pain is a very common symptom in the terminal phase. And it can be sometimes appropriate to look for reversible causes. So there might be oral candidiasis or what we call thrush. The bladder, the patient may have developed urinary retention. When did the patient last open their bowels? Do they need to have a suppository? Are there pressure sores that we have not examined and found? Even in an unresponsive patient, it is possible for a patient to experience pain and for them to display pain. And so careful observation is required. Are they moaning? Do they look as if they're frowning? Are they trying to change position in the bed? And ask yourself, ask the nurses what they think, but absolutely also ask the family what they think. If they think that their family member is not comfortable, then please definitely believe them. I mentioned before about the components of nursing care, and one of them is pressure care and the hygiene of the patient. So pain medicines should be given before the patient receives these nursing interventions, because otherwise that may be more distressing for them. And so suggesting to the nurses to give some morphine or some other, whatever the available pain medicine is, 15 minutes, half an hour before. So I've already mentioned the use of the subcutaneous route, but it is possible to give medicines per rectum, in the mouth, or against the cheek, or underneath the tongue as well. Thank you. So a patient who has been on opioids, such as morphine, should have that continued in the terminal phase. And what we administer them should be reviewed now on a daily basis, because the doses may need to change. There can be and frequently is, a very rapid increase in pain in the terminal phase. The closer one becomes to death. And so a rule of thumb that I keep in mind is I think that the pain is mild, I would increase the dose of their opioid by maybe 1/4 or 1/3. If it's moderately severe, by 1/3 to 1/2, and if it's severe, by 100%. The other way of doing this calculation might be looking at what the patient has needed in the previous 24 hours, and then take that dose and add it into their baseline dose. So the initial order might be 2.5 to 5 milligrams of subcutaneous morphine, and that's given as required, as often as 1 hourly. If there is frequent doses of this being required, maybe 5 or so doses in a 24-hour period, I would then request the nurses to give it regularly every 4 hours. But in addition to giving it regularly every 4 hours, the patient can still have the top-up doses when required. So they have two morphine types of administration. There is the regular morphine every 4 hours, and then there is the SOS, or as required, dose. Thank you. Shortness of breath. So I actually several weeks ago spoke about shortness of breath, and you may recall that I mentioned that is a common symptom even in patients that do not have cardiac or lung disease from their underlying condition. But in the terminal phase, we should look at the possibility of, are there lung metastases, pneumonia, pulmonary edema, compression by lymph nodes? Are there effusions? Is the patient anemic? Are they anxious, or is panic a problem as causes of shortness of breath? Depending on the goals of care, depending on the patient's wishes, we may want to actually treat some of these in the terminal phase. I will make specific mention of pulmonary edema because that is very common, and that I do, in certain cases, administer furosemide subcutaneously or intravenously, even in the terminal phase, if the patient does have fluid overload. Thank you. And so, again, you would probably recall most of what I'm saying here, that opioids will be used in the same manner that we use them for pain. We would use it for shortness of breath. So when I was talking about the management of shortness of breath in the palliative care patient that was not terminal, this was a few weeks ago, you would remember that I said that the evidence tells us that a dose up to 30 milligrams orally per day is evidence-based. So that dose restriction would not necessarily apply in the terminal phase. Benzodiazepines won't necessarily relieve the shortness of breath itself, but they will relieve the anxiety, the restlessness associated with the shortness of breath. So that could be a medicine such as lorazepam or midazolam or clonazepam. And I do recall that Tara had shown me the essential medicines list from Bhutan. And so whichever benzodiazepines is available in your facility or in your community, the dose can be adjusted and given either by injection or by mouth, or even per rectum. With the patient, whether they're short of breath or not, when the patient is in the terminal phase, the family members will often spend a lot of time sitting by their side of their loved one, looking at the breathing pattern. And that's the most noticeable, way of seeing how the person's condition is. And we should talk about that with the family. If we see rapid shallow breaths, that is often seen very close to death. There may be periods where they stop breathing, or it goes through patterns of breathing slowly and then faster and faster and faster and then stopping. Cheyne-Stokes respiration. That is very normal in the terminal phase. Looking at what would be a way of telling the family if death is close, then certainly the rapid shallow breaths would be what is most seen just prior to death. Sometimes I have seen patients and it's hard to even tell whether they're breathing or not. It can actually be difficult to know when death occurs. What is the temperature of their skin? Has there been a change in the appearance of the colour? Has the urine output dropped? Can I feel any pulses? Thank you. Just a very brief mention about nausea and vomiting before I hand over to Gauri, and that's to say that this fortunately is less of a problem in the terminal phase unless the patient has a bowel obstruction. But if nausea or vomiting is present, then commonly I will use either haloperidol or metoclopramide, 1 milligram twice a day of haloperidol, or can be given as required, or up to 30 milligrams or so of metoclopramide per day. And both of these medicines can be given either intravenously or subcutaneously. So that's all that I had to say. Before I do hand over to Gauri, if there are any quick comments or questions, happy to answer them, or if you wanted to put it into the chat. Okay, Gauri, over to you.
Can everyone see my screen?
Yes.
Yes,
Excellent.
we can. Yeah.
Okay, and you can hear me loud and clear. Fantastic.
Yes, we can hear you.
Okay.
Yes, yes.
So thank you so much, Anil. And yeah, at any point, if anyone has any questions, you can put them in the chat and we can discuss it after the presentation or then and there. So thank you so much again for this opportunity to talk to you all today. Just before I start, I thought I should quickly explain to you why I put that little statue mural photo in there. It's called as Caring Hands by Charlotte Meyer. And it kind of resonates with what palliative care means, I think. And it's basically a holistic approach with contributions from different healthcare professionals to help the patient, basically. So I thought that was quite relevant. So today we'll explore management of delirium and agitation in palliative care and in end-of-life setting. Okay, excellent. So today, after introductions, definitions, and assessments, we'll talk a little bit about causes of delirium, and then some non-pharmacological options and some pharmacological approaches to both delirium and then terminal agitation as well. You have to pardon me, I've got a bit of a sore throat, so I might be a little bit throaty right now, so apologies. So just to start with, I just wanted to define delirium a little bit. So delirium is, as we know, a distressing experience for our patients and particularly their family members and carers, I think. Of course, it has got such a high prevalence. There was a study when I was researching for this topic, there was a Scottish study that was mentioned that about 30 to 85% of palliative care hospice patients could experience delirium at some point, so which is a quite a significant percentage there. So as we know, delirium is the acute or recent development of confusion and altered consciousness occurring in a fluctuating manner. So they could be lucid at some point and they could be delirious the next, I guess, minute or the next hour. For example, exacerbation of confusion at night, that could be a very good example of this. It is
Sorry,
characterized
Gauri.
by, yeah.
Sorry, Gauri. I think some of them are not able to hear you properly, so they've mentioned a bit louder if it is at all possible. So just wanted to mention because I think there's a comment who says a little louder, please. So if there's anything you can do about it. Otherwise, I can hear it properly, but looks like some of them are not. So that's why.
How is this? Is that a little bit better? So
Yeah,
is
it's
that a
better.
little bit
Thank
better?
you.
Yeah.
Yes, it is better. Yeah.
Okay. I
Thank
might
you.
just hold
Thank
my
you, Gauri.
mic a little bit. That's okay. All good. No, thank you. I'll just hold my
Thank
mic
you.
like this. That's okay. So yeah, sorry. So it's characterized by disorientation, reduced attention and concentration, or some memory deficits and sometimes perceptual disturbances like hallucinations or delusions or delusional beliefs or other disturbances. We usually get things like, there's a green person standing in the corner of our room when it's actually not a green person, it's a little pot plant that's at the corner of the room. So as Anil mentioned as well, how the room is how the room is kept is actually quite quite important. Now, delirium could be of three types. So, roughly distinguished as a hyperactive delirium, which is increased activity and heightened arousal. Hypoactive delirium is usually withdrawal or slowing of activity. And then you can always have that fluctuating pose, that mixed pattern between activity.
Hi, my name is. I have Brian.
Hypoactivity. Now delirium is abrupt onset, but maybe also subacute in those people with dementia or as in a background dementia. Again, of course, as Anil mentioned about pain management, the pain management is one of the most important goals in palliative care. And I think we already know that unrecognized or unresolved pain can definitely precipitate delirium and contribute to pain as well. Delirium is increasingly common as death approaches and should be recognized and treated quite early. Restlessness or agitation can be extremely distressing symptoms in the last days of life. And as Anil mentioned, also for the family and friends as well. That's why I guess prompt recognition and treatment is quite important for everyone really. Accurate history from someone who knows the patient is quite important. So the grimacing or the slight changes in the facial expression, or is this the normal behavior for this patient, or understanding the baseline is quite important. So an accurate history from someone who knows the patient is quite important. A brief cognitive assessment tool such as confusion assessment method or CAM can be used as well. I can share that resource a bit later. We'll share that a bit later. Now, let's talk about causes of delirium. And the best way to remember anything, for me at least, is to use a mnemonic. I love mnemonics. So D is for drugs. So basically, or lack of drugs. So withdrawal of medications like benzodiazepines or narcotics or alcohol or anticholinergic medications, those drugs themselves and the lack of, so like rapid withdrawal can precipitate delirium. That's quite important to know because you know how Anil mentioned about rationalizing medications in the end stages. We quite need to also understand what the half-lives of the medications are. Like things like cholesterol medications and all, yeah, that could be absolutely, those could be stopped cold turkey. But then if somebody is on a medication with long half-life, it's quite important to perhaps slowly taper it and then stop it on short half-life. Um, and then of course the E stands for environmental factors, such as you know, if lack of assistive devices, for example, hearing aids and eyeglasses and contact lenses, that that could precipitate delirium as well. Things that could help would be reorientating the patient, using sleep protocols, mild music, keeping the noise to the minimum, can help. Now, ambulation is a tricky one at that end of life stage. But if that is at all possible and you know the death is probably not imminent in that earlier phase, that could help a little bit. And then of course managing anxiety and pain. Then L will be a low oxygen. So if there are other causes like myocardial infarction or pulmonary emboli, etc., that can precipitate delirium. Infective causes such as pneumonia or urinary tract infection, skin ulcers, sepsis, shocks. Those are quite important to note as well. R is for retention, so that will be retention of urine or stool, so constipation or urinary retention. I is intracranial, so things like stroke or a transient ischemic attacks, or trauma, or like blunt trauma. You will be under hydration or under nutrition. Another, that's again a little bit, I guess, challenging, as Anil mentioned as well. That's something to note. Of course, and then we have metabolic causes, such as when I think about metabolic, it's like electrolytes, like hypos and hypos and space occupying regions. And then S will be, of course, sleep disturbances, the lack of sleep. Yeah. So I think other thing is like not all of this we can really manage, if you will. Like we can apply our holistic approach here and manage the most, I guess, most like low hanging fruits, as Anil was mentioning. Things like deprescribing and things, but like hydration, that's a very tricky one to manage. Now, there are many aggravating factors, as I've mentioned before. So if a patient has a background of dementia, that definitely makes people more susceptible to delirium. Pre-existing cognitive impairment, like an acquired brain injury or alcohol-related dementia, pain, urinary retention, constipation. I've mentioned all of these before. Unfamiliar excessive stimuli, like loud noises and stuff, that can definitely aggravate delirium. Now, non-pharmacological management is the first line, as it is in a lot of our management strategies. Consider investigation and treatment in context of the stage of the illness and acuity of changes in mental status. And of course, the advanced care planning. Treating underlying organic causes like fever and constipation and anemia, that could be first line approach. Then of course, in those last stages, we probably would not be treating infections as actively. Ensuring safe, secure, familiar environments as well. Things that we tend to do on our own is like hanging family photos or presence of people quite well known to the patient, and avoidance of dark or bright lights, and basically preventing that sensory overload or overstimulation. We don't want that. And then simple, like we had a patient once, was quite disorientated and delirious. And I think their main issue was that they didn't know what time it was. It was as simple as that, as just hanging a clock on the wall. Just a date reminder that we all need to be orientated every day to our day-to-day lives. So that just did the trick for this patient. Ensuring that the patient has minimal sensory deficits, like using glasses or hearing aid, making sure they're there. There's a really good delirium clinical care standard. So if you just Google Australian Commission on Quality and Safety in Healthcare delirium care standard, that will come up. I can also distribute that a bit later. That's definitely worth a read. Now, with pharmacological management, it's quite important to note that severe hyperactive delirium is a behavioral emergency. Now, again, in an end-of-life setting, very likely the clients or patients will be in the hospital. Management of acute agitation will be determined by the cause, as I have mentioned before. Here in Australia, there are no really kind of drugs available to treat specifically approved by our therapeutic food administration to treat delirium. But of course, in end of life setting, choices of drugs are like haloperidol, second generation antipsychotics like risperidone or olanzapine, or quetiapine that can be used. Yeah, I'm reading a question there. We'll answer that a bit later. Thank you. And then if the patients are unable to tolerate haloperidol, so particular situations would be like AIDS, like HIV makes CNS more sensitive to dopamine antagonists as well. Then, of course, a second generation antipsychotic would be more appropriate. Now, examples of second generation antipsychotics include risperidone, olanzapine, and quetiapine. In symptoms of extrapyramidal side effects, we probably don't have to worry too much about it. It sounds a little bit weird saying that we don't have to worry about it, but I think symptom control and I guess looking after that patient in that end stage or alleviating the distress is, I think, of more importance. Clonazepam is also being used. We use it with regular subcutaneous. We use it here as a regular subcutaneous route, but we don't use that in a syringe drug or so, which is like a continuous subcutaneous injection that is very commonly used in Australia in end-of-life stages. Well, now agitation, or we'll quickly talk about this in this time. Yeah, agitation or terminal restlessness is quite common as death approaches. Usually, it's like a pre-death event. It perhaps is best conceptualized, I guess, as a prolonged delirium. This may indicate physical, psychological, or spiritual discomfort as well. Predictors of terminal agitation could be chest infection, or unexpected fever, poor oral intake, weight losses, significant weight loss in the end stages, of course. Presence of bed sores, verbal and motor behaviors are quite significant. Patients may be restless and unable to find a comfortable position. As I mentioned before, they are moving from side to side quite often, or trying to get out of the bed, or pluck sheets, or pluck in the air. That could be that sign of agitation as well. In the last days of life, agitation can have many causes. Poorly controlled pain is a very big issue. And then, of course, emotional distress, medication toxicity, or metabolic changes. That's why looking at those unnecessary medicines is quite important. Other causes include withdrawal from medicines, like alcohol or nicotine. They're smoking before, illicit substances, which I haven't seen much in practice myself. Um, General measures were, as discussed before, in the non-pharmacological management. I'm not sure whether in Bhutan you do have access to nicotine patches, but we do have access to nicotine patches here in Australia for patients who may be withdrawing from that from if they were smoking quite a lot before. We usually tell them to do that in one or two cases that is several patients for us who are like chain smokers, and we put patch on and they were better because they were withdrawing. There's a really good resource created by the Clinical Excellence Commission. I can distribute that a bit later as well. It's called as a it's a part of the end of life, last days of life toolkit. It provides pretty good flow chart to manage restlessness and agitation during the last days of life. I won't delve way too much into it. That flowchart is very self-explanatory, which I will distribute in later. It kind of talks about if you're giving regular antipsychotic, or if the patient's being regular antipsychotics or benzodiazepines, then what to do. And if they have not been on regular antipsychotics or benzodiazepines, then what to do, and what PRNs you can give. Of course, if that syringe driver option is not available, then they also recommend how to give the subcut, like at what frequency to give intermittent subcut injections as well. So in conclusion, as I said, restlessness and agitation can be extremely distressing. Acute delirium is a medical emergency. Basically, the day and night reversal could be quite distressing. A delirium could be multifactorial, and non-pharmacological management is first line. But at end of life stage, that may not be possible, and we have to go to a pharmacological management that is straight away. Now, with secretions, very quickly, they're also known as death rattle or noisy breathing. It's quite a common symptom at end of life, occurring in 20 to 90% of patients. So quite a big range there, but it's quite it happens quite often. The cause of terminal respiratory secretions is quite unproven and controversial. But from what I have read and studied, it's the most accepted explanation is that when a patient is not able to cough effectively, or they are not able to swallow and clear secretions from their oropharynx or trachea, it causes a pooling of secretions in their throat. And then inability to clear secretions from upper respiratory tract, which is the oropharynx, of course. Then when air passes through it, it results in that noisy breathing or that rattling sound. It can be caused due to infection as well, or aspiration. Respiratory secretions are very common symptoms at end of life, and not so much to the patients themselves, maybe, but more for family and carers. So family and carers find it very, very distressing when they hear that and they feel that their loved one is in pain or in discomfort. It's really important to explain the cause and reassure them that it's a normal part of the dying process, and it's unlikely to be distressing the patient. I read a little bit about like death rattle being a strong predictor of death. So after commencement, the median survival time is about a day, 24 hours. I've given all the references at the end of this slide as well. So if you're interested, you can go and have a look at those. One of the assessment tools that I have studied, I would say I haven't really used it myself in practice from a pharmacy point of view, but Anil might be able to shed a bit more light on that a bit later. But one of the assessment tools is called as lateral intensity score that can be used to guide clinicians to identify terminal secretions. I guess few other reasons a lateral can happen is due to respiratory secretion, infections, as I said, cardiac failure, GI obstruction, pulmonary edema, and that's when, as Anil mentioned, they may use diuretics, a small dose of diuretics for that. So non-pharmacological approach, there's some quite simple things we can do to help with that. So repositioning of the patient might be helpful to shift the food secretions. So like from shifting from one side to the other, they can reduce noise and encourage postural drainage as well. Like from the nursing staff, like from the maneuvers that do what I have seen, it's not one position is like the best. They have to try a few different positions, and some patients might benefit from one position and others might not. So you have to try different things, what suits that patient or for that works for that patient the best. Mouth care, as Anil mentioned, and position changes, of course, will maximize comfort and help with secretions as well. So consider seizing any additional subcut or IV fluids, as Anil mentioned as well. Patients with advanced head and neck tumors or cancers may experience excessive drooling. I've seen that a little bit in my practice. So if there is visible stool secretion in oral cavity, then yes, a mild suction may be used. However, any suction beyond the oral cavity is very likely to stimulate a gag reflux, and it's very distressing for the patient. So to be honest, in my practice, Anil might be able to shed some light later as well on this, but maybe once I have seen a little bit of suction being used just in that oral cavity, but it's usually contraindicated. It's not used. It causes quite severe gag reflux, reflex. And of course, assessing the patient regularly is paramount importance. Now, pharmacological actions, antimuscarinic agents like hyoscine or glycopyrrolate. I'm not sure glycopyrrolate is available in Bhutan or not, but hyoscine, maybe the butyl bromide form of it, can be used to reduce salivary secretions. These agents inhibit salivary secretions more than the bronchial secretions. So currently, there are no particular medications for one other. We use glycopyrrolate more often than hyoscine because of its permeability or non-permeability to the blood-brain barrier. Usually they say that non-pharmacological management has better success anyway. Atropine, I've seen atropine being used as well. We in Australia, we get atropine eye drops, and they are used sublingually. It's quite an off-label use, but that dries out the secretions a little bit as well. Now, if these drugs are to be used, they should be used as soon as the atropine begins, because they can reduce the production of new secretions, but they do not affect existing secretions. So existing secretions would still be there. Monitor for patient's response and adjust the dose as needed. Hyoscine butyrylbromide, as I said, is not recommended as first line due to that permeability thing I was talking about, and also it can potentiate delirium and is a bit sedating as well. And so atropine can also cross the blood-brain barrier as well and can precipitate delirium. So both glycopyrrolate or norglycopyrrolate or any of these drugs are likely to cause or exacerbate I guess severe delirium. We usually recommend glycopyrrolate as first choice anyway. Some side effects may include sedation, dry mouth, urinary retentions or palpitations. Glycopyrrolate, again, I'm not entirely sure if that's available. It's an anticholinergic agent, and yeah, it basically works in that fashion. Hyoscine butyrylbromide blocks the effect of acetylcholine in the GI smooth muscle for the relaxation, and atropine reversibly blocks acetylcholine receptors. Again, I'm going to refer back to that really good flowchart I'm talking about, the Clinical Excellence Commission's the management of respiratory tract secretions. Again, I'll make sure that I pass on that resource. It's really good approach. Considering glycopyrrolate may not be available, I'll talk a bit more about hyoscine dosing. Hyoscine butyrylbromide, usually the starting dose is like 20 milligrams subcut every 2 hours when needed. And yeah, usually we don't go any more than 6 when needed doses. And of course, if more than 3 PRN when needed doses are required, we usually give prescribe regular anti-secretory medications. Yeah, I'll send that CDC guideline. Now, in conclusion, noisy breathing due to respiratory secretion may be referred as death rattle or rattling. I find that counseling of relatives and caregivers is very, very important in that regard. Not all people find the symptoms distressing, but for those that do, this needs to be considered. And then, of course, repositioning from side to side in a semi-upright position may have better success than medications. And then suctioning needs to be limited to the oral cavity to avoid the gag reflex and distress. And of course, give when out care to prevent trauma is also very and that's it from me. We'll stop sharing.
Thank you
That's it
very
from me.
much.
Thank you.
Thank you. Thank you very much, Anil and Gauri, for such a comprehensive presentations on the end of life care, how important it is and how much we can do to ease their suffering. It is, end of life is the most difficult moment, but also we can see, listening to Anil and Gauri, that we can do so much more to ease that suffering. Obviously, we are not going to stop from the patient from dying, but so much more we can do to make a difference in how the families feel and how the patient is also made to, as much as possible. And with that, I think there were a couple of questions and answer sessions as well happening in the chat box. I think the main concern was around death rattle, and also Anil was clarifying on how much to, as Gauri also mentioned, how much to suction, when to suction, and as much as possible know that whether suction really makes a difference. I know it's sometimes, as Anil also pointed out, and Dr. Sonam, that death rattle is sometimes so much a kind of disturbance to the family members and the healthcare professionals. And I think one thing I feel is listening to Anil and Gauri as well, that it's important that we know what we are doing and trying to say, because at times we ourselves are not very sure whether it's really causing a problem to the patient, and so we are not very sure whether to suction, whether not to, and so we are not able to convince or communicate with the patient party. So here in this discussion, we understand that it's how you communicate, that it is actually not so much a problem to the patient, but it sounds like it is a problem, but it is actually not so. I think for now, in the interest of time, I will invite Nilima to start with the case presentation, and then maybe have more discussions after that. So over to you, Nilima.
You're muted, ma'am. Kindly unmute yourself.
Okay, good evening, everyone. Thanks for this opportunity. I hope I'm audible, by the way. And
Yes.
then let me share an experience which I have experienced during my clinical practice. And then let's learn from that. And then thanks to the previous speakers, many of my concerns are actually addressed through your presentation. Let me share my screen. Okay. Also disable the screen sharing. Can you just enable me to screen share?
Yeah, you can try now.
Is it visible?
Yes, yes, yes.
Yes, it is.
Let me quickly go through my PPT. Thank you, Ma'am Tara, for helping me out. And then let's quickly see this case, which actually left us in front of me. And then I have lots of memory. Let us go through the slide. This was 36 years old male who was diagnosed to have advanced C of left buccal. Actually, he presented to a district hospital. It is southern part of Bhutan, with a small ulcer in his mouth, and then unfortunately he was sent back with some vitamin pills. And then over next 3 months, it continued to progress, and then he revisited the hospital. The ulcer was quite big. It was from extending from the angle of the mouth towards the TMG area, involving this gingival, buccal sulcus. Then the biopsy was taken. Unfortunately, it came out to be moderately differentiated squamous cell carcinoma. Then further, now the process started. Then they had to refer him to a facility where there was a CT scan facility, and wanted to do the staging of the tumor. Following the biopsy, the swelling started, and then that till then he didn't have much of other symptoms, though there was ulceration, but then no pain, no swelling. And then he left for the National Referral Hospital, where he was subjected to CT scan. CT scan. He was apparently very active male. He was working as a driver with a government agency. He was, as I told you, he was 36 years old male. But unfortunately, he had a very high risk behavior. He aggressively chewed tobacco, betel nut, and gutkhas for last 4 years. And then he also smoked and then developed the ulcer, which he initially managed with some locally available ointments and application, and then also visited the hospital later. Are you able to see my slide, Ma'am Tara?
Yes, we are, but it's not in the presentation setting. Yeah,
Okay.
yeah, okay, good. Yeah.
And when he basically visited to us, he had already had an advanced CA. One left side of the face was already swollen up. There was an ulcerated wound, which has lots of oozing. And then fortunately, his saturation was maintained. Other vitals are basically normal. though he was agitated, restless, there was emotional outbursts at times. Earlier presentation to initial base hospital was very mild, actually, a painless ulcer, no swelling, all those things. But when he came to us, it was already advanced. And so how the journey started, later 2022, there was ulcer, biopsy confirmed cancer. After CT scan assessment and then staging of tumor was done in the National Referral Hospital, then he was referred to India for chemotherapy. And then I think going through his document, what I feel was it was just kind of a palliative chemo for him at that point of time. First setting, he tolerated well, and then as he was waiting for the second and the third cycle, and the tumor started to aggressively grow. And then finally they decided to come back home, and then he was released by the hospital there, and he came back to National Referral Hospital. And then from there, because still the patient had hope, he denied that he has cancer, as he had few of his siblings working in the hospital as support staff. They wanted to come to Central Regional Hospital. That's how they landed up to us, because the route started from Phongsling, they went to Thimphu, then they went to Calcutta for chemotherapy, and then landed up to CRRH. And then he was here for a very brief time. Actually, we just got him to care for around 2 to 3 days. He was admitted on the 2nd of April 2023, where there was still, the hospital still had lots of COVID restriction about visitors and all those. And then on 4th around in the evening, he expired in the surgical unit of the CRRH. He was looking at his psychosocial aspect of his life. He was first of 4 born, the first child. When he was around in 7th grade, her mother expired, probably to alcohol. Then he was brought up by his grandmother, and then he has 4 other siblings. 3 of them work as support staff in our hospital. And then when they went to Calcutta and then came back to JDW, they were thoroughly explained about the prognosis of the disease. Basically, they had a good understanding. They understood that he's not going to live long. Initially, they were coping well, but as patient condition deteriorated, as he went into active dying process, things got very difficult. And this was, and then patient also had lots of fear. Occasionally, he used to get suffocated, and then the saturation started to drop. One of his coping mechanism was through throwing tantrum, anger, and at times he used to cry. And there were lots of regret he expressed. And then on the day before he died, he started to hand over a very important task to his wife. Actually, then we knew, okay, maybe something bad might happen in few days now, because one of the very touching incidents is that he was brought up by his grandmother, and then every month, end of the month, he used to recharge her TV cable. No, and then that was his very favorite job, I think. And then finally, he also decided to give that task to his wife. Whatever amount of money he had in his account, he transferred to his wife. Then it was the time we thought maybe it's time for him to go now. Then he had stepmother. She came with all her goodwill, but it created some kind of disharmony among all the siblings there, which also created the passing away was quite difficult for him by then. And then coming to medication, because he had lots of what I didn't like about his dying, like what I see in my ward is 50% of the death in my ward is basically death related to cancer, because people have stopped people somehow bring dying patient to hospital. I don't know. I think maybe it was different previously, but now even if they are very terminally ill, death rattle, the active dying phase, they bring them to hospital, and then we have to face all this process. And then when we were looking at this person, looking at death, no, for him, he was looking at death. We were looking at it at four, I think, probably 3 to 4 different direction. Attendant with lots of expectations, we trying to help him. He don't know what to express and not ready to go. So it was a different approach, a different perspective of facing the death then. And then and then we gave whatever available drugs were there. Didn't make him comfortable. We gave morphine infusion, pethidine was given round the clock. Again, IV paracetamol was given, fentanyl patch was applied. But he was restless, air hunger, I don't know, in pain. Or actually, I sometimes feel maybe he was not in actual pain, or was that just the fear of pain? Sometimes I feel like to associate that maybe death is not always associated with pain. Looking at him, all the medications were given, but still he was complaining of pain. That is very unfulfilling from our part. For me, actually, I was closely monitoring him with him till he died. Though my shift ended by 2 o'clock, I continued staying with him because uh, I, I was the most senior most staff on duty, and then other 2 nurses were busy with the routine thing, and then I was by the bedside, uh, and I could not help actually. I called the doctor, and then that is one of the things I regret. Maybe there were some other drugs which Madam explained earlier could have helped him somehow to die peacefully. Main concern were like fear, and family were distressed. They didn't want to let him go. He also didn't want to go a few days back, but then gradually he had some kind of acceptance. And then we were trying to make all the transition very peaceful, but the whole scenario, those who of us who work in Bhutanese hospital, we know there will be lots of relatives. We fail to understand the perspective of that person, how he wants to die. I like to die peacefully in a room, or do I want to die in front of everyone, all the relative, doctor, nurses, in a very pathetic situation. This was the situation for this guy. There were lots of attendants rushing in, out, father, mother, 4 siblings, and their relatives. And then we were there. And then it was like he dying and then we watching. I wish I could have, I asked him how he wanted to die, but definitely I didn't have the courage and the expertise to communicate with him and then know his inner feeling, what he wanted actually. And then finally, when his he stopped breathing, I was there. His heart didn't stop. This is my second time experiencing this kind of thing. Previously, there was one patient who died of CA esophagus. He stopped breathing, and then the heartbeat was there for next 40 minutes. Then I could not leave him, and then I could not declare he's dead. No, we were waiting, and then when his heart stopped, then we declared, okay, he is no more. And then the wife collapsed there, and then we had to take her to the next cubicle. Father was a non-asthmatic. He had severe wheezing. We had to manage. And then the doctor attending the death, and some of the nurse had to rush to the next room and then manage the relative. But I feel happy that we could help them in all possible ways, that we took care of family, though we could not actively manage his distress and dying. At least we are happy that I was there with him. And so, and in the summary, I would like to say that we lost a very productive young man to lots of contributing behavioral risk factor. Actually, in one of the talking session I had with him, he mentioned that if I get better, I like to go to BVS and then explain all this, and then tell them that taking these things are not good. And then he also touched upon saying that maybe people, though I think he had some bad experience down there in a corporate hospital, and then he was trying to mention that I think people should be more empathetic, and then should spend some time talking to patient. So those were the thing he wanted to tell the general public if he had survived. Unfortunately, he couldn't do that also. And then as per his desire, and then he was very close to his grandmother, he was taken back to his village, Wangdi, and all the rites were performed there. Later, when I meet with his, I think they all fall back to their own normal thing, no? And the only person who grieve is his grandmother, and then his first death anniversary is approaching, and then I think it is always very difficult to manage the first, no? And then they are preparing to do that well. Then one thing, reflection, maybe it came very late in my life, is that we know that we prepare so much for the birth, but we have not seen anyone actively dying. That causes, looking at those two young siblings of the patient who died, gave me a reflection that maybe they had never seen a dying person, how person die. You know, some die very peacefully, some die with so much of struggle. And then thereafter, I started to show a small video clip to every family member who is caring for terminally ill. So it has become a practice thereafter that, okay, definitely they have not seen any death. So if grandmother dies, probably she will die with her open mouth. So that is one thing I have learned. So if in every impossible way, as a professional grooming the young nurses, I think we should all try to teach them what is active dying, and at least through video or whatever possible sources we have, can have a dying patient to show them, so that mentally they can recognize and then understand how patient die. And I definitely, as I told earlier, I regret not knowing how he wanted to die. I want desperately need like to make the dying process graceful, peaceful. Mostly head and neck cancers are very difficult, and then suffocation, very small area, the pressure symptoms will be there, and then suffocation will be very aggressive. Then if there are any medicine to help his, maybe later I understood that maybe high dose of morphine could have helped him, but we didn't have that in prescription. Maybe early tracheostomy might have helped him if they had done thorough counseling at the earliest stage, and then the tracheostomy was created. And then good thing is that for this patient, we managed to have one doctor by side. I was there full time. Relatives were all allowed inside, though there was lots of COVID restrictions. Provided time to mourn, managed other relatives. So this was the good thing we are proud of. But definitely his dying process was not that smooth. I think everyone can relate to my situation, because this is the scenario in every Bhutanese hospital. When somebody is dying, there will be lots of visiting, watching, and then you don't know what to do. Patient is struggling. So I think we all can relate to this case, and then maybe do better by explaining them. And really, I wanted to know, from here on, I want to know how they want to die as early as possible. Thank you so much. Hope I was clear.
Thank you. Yes, you were very clear. And thank you very much, Nilima, for presenting here the ground reality of how death normally happens in our setting and the challenges we face. And and the importance that you mentioned about how you want to make a difference and how much you want to learn to make it better death. So as usual, we run out of time, but is there any pertinent question or as maybe when someone's preparing for a question, would Anil and Gauri have any, any advice or suggestion or a comment to make on this case, a certain clarifications, so that things would be done better, or what went well, what could have been better? So Gauri or Anil, please.
Gauri, would you like to go first?
You go ahead, Anil. My voice is failing me.
Sure. That's a wonderful presentation, Nilima. Thank you so much. And how, yes, sad and tragic it was, obviously, for him. But I think that really what I was struck by is the heartfelt expressions that you gave of care and compassion. 10 months after this man has passed away, it's still clear. A few comments. I think that absolutely it is possible that maybe he was not experiencing pain towards the end. I think that always we should assume, however, in these types of conditions that pain is present, because dying from head and neck cancer is definitely a painful condition. But there were so many other factors here. The existential distress that he potentially may have been experiencing, a young man leaving his young wife, the anger that he had, but also, unfortunately, the anger that the family had. They may have actually, the responses of the family may have actually increased, sadly, his distress. And obviously, the efforts to try to deal with an angry family need to be so carefully handled. And it's very difficult, because often when it's a natural human response that when someone is angry, some people will sadly respond with anger. And so then if staff respond in an angry fashion to an angry family member, it actually does not help the situation. And trying as much as possible to understand their anger, understand his anger. The looking at the list of medications that he was given was interesting. I think that the glaring absence for me was for benzodiazepines, and whether there were any of those that might have been able to have eased either the suffocation sense that he was experiencing, or just the fear of suffocation, the fear of pain. And I think that the final comment is clearly your dedication in caring for him, staying back at the end of your shift to be with him, especially with you being the senior most nurse on shift that day. Hopefully the team around you could see the leadership that you displayed.
Thank you so much, sir. Actually, yeah, I also, when Madam was talking about lorazepam and all those things, I definitely wrote it down that okay, diazepam was missing, and then it might have helped him actually.
Just to start with, what a great presentation! Like it was evident, your dedication and how you handle things in the situation and the resources that you have had. That was just amazing and mind-blowing. Thank you for sharing that. My comments are very similar to Anil. One was benzo. The other thing, and which is not really a patient-related comment, but like, are there any resources available for you as caregivers to debrief about your feelings as well? Is there anything available to you at all in your setting as to, obviously, like when you're so close to a patient and their families, looking after them, at some level, yeah, at least I find it a bit confronting / distressing post as well. So I'm not sure if you have any resources for yourself or caregivers for debriefing.
Actually, we don't have it here, but only source of coping is through speaking to your colleague, come home and then share with your family. That's it. And then for family also, there is no specific organization where they can go. But if they have real issues, then we refer them for family counseling. But actual debriefing doesn't happen.
Anil, is there anything that we like in particularly with debriefing for family as well? We don't have anything particular here that we of. I'm just trying to think like at least in our setting for family here. Yeah.
No, I don't think so. I think that very much for the family, ensuring that they use their own community resources. So basically for us as doctors and nurses in that early phase after the death, not interfering, allow them to come together, support each other through their own grief, their cultural practices. But then down the track, later on, usually it's recommended several weeks later, trying to reach out to them and see how they are. But certainly for you as a team, early on, as quickly as possible, talking with each other, supporting with each other, absolutely like what you do, talking, even coming home and talking, saying it to your family rather than it actually building up inside you. Because so often the reality is that people outside of our work do not understand what we go through and what we're experiencing. And so the last thing that you would want to do is come home in a bad mood, be angry, take it out on a loved one that is thinking, why is Neelima like this today? What's happened? I don't understand.
Yeah, completely agree. And I think so we can clearly see here that what it is like when we have a dying patient in a setting where there's no palliative care. Although without any knowledge or skills on palliative care, all of us as workers would want to make it as peaceful, as comfortable, and as respectful. But because we didn't learn about palliative care, we at times feel we are helpless. And with this very important session today, thank you so much, Anil and Gauri. I feel that we are better equipped and, we will make so much of difference, I can see. And thank you, Nilima, for bringing this case. And it clearly tells us how things has been going on and how we can do it better next time. And so I do remember some of the patients that I've lost when I was in a clinical practice. And those cases never goes away from your lives. But today with palliative care, we can make a difference to future dying patients and their families. And with all these medicines and the different non-pharmacological and pharmacological approaches, along with that empathic communication, I think things really can go better. Just briefly, when I was losing my family member, the case that I presented last week, we had a room full of family relatives. But because I was little confident with palliative care, we could take control of the relatives. We requested to put their phones in silent. We requested to speak in a low volume. We demonstrated that ourselves. And so everybody who came to pay respect to the person who was dying maintained that. So through those ways we can, because in our context, families would want to come in, and it is not right for them stopping not to come and see their loved one dying. But we can, with practice, I think last week we learned communication skills can be practiced and always improved. I think helping the family members who are themselves very distressed understand about the situation and how they can help all of us to help this person who is dying. And so I think very, very important lesson today, a very important session. And I think, is there any, and what we learned to help us next time? Exactly. So I think the whole session made us a better healthcare professionals, to all of us attending here. And once again, thank you very much, Anil, Gauri, and Nilima. I think with that, I will hand it over to, do you have anything to say, Anil, Gauri, or Nilima, any last points? Okay, thank you so
for having
much.
us.
Thank you so much. And I think I'll hand it over to Sangeet then. Lovely, very nice presentations.
Thank you, Dr. Anil and Gauri for the nice presentations. Thank you, Neelima, for the wonderful case presentation. Thank you, Tara, for facilitating the session. Thank you all for joining and making it in practice session. Let's see in the next session, in the final session. Thank you. Bye.
Yes, thank you everyone.